All right. So, hi, welcome to today's session. So, today we will be discussing on the labor care guide. Okay. So, basically, most of you may not have heard this, but since it's a new thing, it was introduced in 2020 by the WHO. It's something which can come as a potential question. So, we won't go into too much detail, but just enough for you in case this comes as a question, because recently Robson's classification was asked, and that was also a recent WHO initiative, and this is something which is again new. And if faculty from major medical colleges are making your question paper, then this is definitely a potential question. All right, because many of the major medical colleges have started using the labor care guide in the labor rooms, so you are expected to know at least a little bit about the labor care guide. So the labor care guide is nothing but a newer kind of partograph, which is called they label it as the next generation partograph. So it's nothing. There's some new things, but it's not very new. A lot of old parts of the partograph have also been incorporated, but we will concentrate on what are the new things. All right. So, as usual, those who have not subscribed to my channel, please subscribe, like, share, comment if you do like the videos. Okay, so let's just go back to a little bit of history. To understand the new partograph, we should know the old partograph, right? So this is the oldest partograph. In 1994, the WHO came out with this old partograph. I think all of you know this. Initially, there was a latent phase and then the active phase. And the active phase they had two lines on the partograph, an alert line and an action line. Okay, so before this, just quickly, what is the first stage of labor? The first stage of labor is the onset of true labor pains to full dilatation of the cervix. And the first stage of labor is divided into a latent phase and an active phase. Now, again, this has also been a major change recently. The active phase till very recently was described from 4 centimeters onwards. Okay, but now the definition for that also has changed, and we will be coming to that because that change is now a major part of the new partograph or the labor care guide. Okay, so let's just go what happened in the year 2000. The modified partograph came out. The modified partograph did away with the latent phase. You can see there's no latent phase here because the latent phase is very subjective. And when the patient actually transitions from latent phase to active phase, no one really knows. So it becomes difficult to plot this. That's why this was done away with. So now this is the partograph which is being followed in most places. I'm sure all of you are familiar with this. Most of your questions which come are based on this partograph. It is still important. You still need to know what is the alert line, what is the action line, but that is not the purpose of today's class. I will just quickly tell you that there was an alert line and an action line, and the alert line was made at 1 centimeter per hour of cervical dilatation, which is the least expected dilatation a primary gravida should have. Okay, and it was started at 4 centimeter. Again, this was taken as the onset of active labor, but this again has changed. All right. The third partograph which came in between a few years after this one was the color-coded partograph. Many of you may not have known about this, but this also came in between again by the WHO. This was mainly for the primary healthcare centers. It's the same as this partograph. The graph is the same. It was just color-coded. So it's easy for midwives or nurses in the primary healthcare centers to identify if the patient is falling to the left of the alert line, that is green, or in between this is orange, or to the right, that becomes red. So they know when to take appropriate action. So this was the history of the partograph. But now what has come, this is the labor care guide. It's a little difficult to see, but I will show you each part of it separately. So if you get something like this in the exam, don't get worried. This is nothing but the WHO labor care guide. And let me tell you a little bit about it, what you need to know. So why did the WHO modify it again? So basically, the WHO said that there was too much medical intervention happening in labor. Labor is a natural process. A lot of over medicalization of childbirth was happening, and that led to unnecessary rise in cesarean sections. And the woman was not owning her body and her own capability. So basically, respect to the mother and communication with the mother, these components were also incorporated. And basically, they said that there is no need to intervene too early. Let her progress. Okay, as long as the maternal parameters are fine, the fetal heart rate is fine, let her progress, nothing will happen. So that is why these changes, one of the reasons why this was made. The second reason why the changes was made, as I said, was definition of active labor has changed from 4 centimeters. There was a study done by Jang et al. A few years back, a major study, and where they said that 6 is the new 4. All right. So what they said was the American guidelines, ACOG also follows that 6 centimeters is the new active phase of labor. Okay. But most studies still say 5 to 6 centimeters. So the WHO has not taken 6, it has actually taken 5 centimeters as the new active starting point of active phase. So if you're asked a question, when does active phase begin? By WHO, it is 5 centimeters. Please remember this. ACOG says 6 centimeters, WHO says 5 centimeters. If you're asked about the labor care guide, 5 centimeters is when active labor starts. 4 centimeters is now done away with. Okay. So the validity of one of the most important components of the Partograph, the alert and the action line, has been called into question in the last decade, as findings of several studies suggest that labor can indeed be slower than the limits proposed by Friedman, who suggested that 1 centimeter per hour. But many studies have now shown even women who progress slower than 1 centimeter per hour have good outcomes. You understand? So that means you're unnecessary intervening. You don't need to intervene. If the fetal heart rate is fine, if the mother is fine, let her progress. That is the basic concept. And the active labor has now been changed to 5 centimeters. Okay. So they took a lot of interviews with mothers, and all the mothers said that they need to be given more respect. They want to be in control. They want to have a natural birth without intervention. So all these components also are reasons why this new Partograph has come into being, and you'll understand it better when we go to it. Okay, so now remember a few points about the labor care guide. Number one, it is primarily designed for low risk women, that is apparently healthy pregnant women. So it is not to be followed in high risk. In high risk, you will require much more intensive monitoring. Remember, the labor care guide is only for low risk women. Okay, if it comes as a potential MCQ, this can be asked. So it is not for high risk. Remember, it is only for low risk women who have no apparent complications. Okay. Second, when should we start it? When the woman enters active phase. And when is the active phase? By WHO, it is now 5 centimeter or more. So when do you start plotting it? At 5 centimeters, not 4 centimeter, not 6 centimeter, at 5 centimeters. So remember these 2 points. It is for low risk women, and it is to be plotted for 5 centimeters onwards, regardless of her parity and her membrane status. It has to be started at 5 centimeter. Okay. Now the structure of the labor care guide. Okay, you all know the structure of the old Partograph. The structure of the labor care guide has 7 sections. Remember this. It has 7. It is divided into 7 sections. Section 1 is identification details. We will go a little bit into detail, but not too much. Okay, just enough for you to know. Section 2 is the new one. Okay, this includes supportive care. Okay, whether the woman has a attendant with her, whether the woman has analgesia, whether the woman is mobile or supine. So all that comes under supportive care, which I will tell you a little bit more. Section 3 is care of the baby. That means the fetal status, fetal heart rate, caput, molding, liquor, all that. Section 4 is care of the woman. That means her vital parameters, her urine ketones, proteinuria, all that comes under care of the woman. Section 5 is labor progress, which again is majorly changed in this, and we will come to that. Okay, section 6 is whatever medication she's getting. Have you started on IV fluids or oxytocin, any pain relief? All that comes under section 6. And section 7 is again new. Shared decision making. What are you doing? You found the findings. What are you doing? That has to be documented. So the new things are supportive care. Okay, the labor progress has changed significantly. And shared decision making, that has been, what are you going to do when you record your findings? What is your plan of management? That has been added. Okay, so let's start section. So this is how it looks like. Okay, this is a magnified view of the first 4 sections. You can see section 1 is identification details. Okay, then x-axis is the time. Okay, the time again has divided into 2 parts. One is first 1 hour, 2 hour, 3 hour, and then you can write her the actual time. Say she comes at 7 a.m. or 8 a.m. or 9 a.m. and then it's also hours wise. First hour of labor, second hour of labor, third hour of labor, like that. All right. Then you have here, you have section 2 is supportive care, section 3 is baby, section 4 is woman, and so, and then labor progress, all that. You see this line here, there is an alert column here. Okay, this is the alert column. So the alert column basically tells us at what stage do you need to be alert. If suppose the woman comes at 7 a.m. and she doesn't have a companion with her, N means no companion, N is for no. Okay, and you write here no. So this is an alert finding. That means you are supposed to encourage the woman to have a companion with her. If she has, say after 1 hour, her sister comes, then you write here yes. So this is a good point. Okay, this is an alert point. Okay, similarly, pain relief. If she says no, that's again a bad point. You should offer her pain relief. Same if she's not taking oral fluids, it's a bad point. If posture supine, so you have two postures, supine or mobile. Okay, so if she's supine, it's a bad point. It's something to be alert. You have to encourage her to walk around. All right. So these are the alert features. Same in the fetal status. Baseline fetal heart rate, if it's bradycardia or tachycardia, it's an alert point. If there are, L means late decelerations. If there are late decelerations, it's a bad point. If there is thick meconium, 3+ meconium, or bleeding in the liquor, blood stained liquor, it's a bad point. If the fetal position is posterior transfer. So I'll just come to each one of them. But what I mean to say is this line, this column is the alert column. If anything, your recordings fall in any of these, then you need to be alert and alter your plan of management accordingly. Okay. Similarly, section 5, this is labor progress. Section 6 is medication. And section 7 is your shared decision making, where you will write what you plan to do now. Okay. So let's just quickly go. Identification is very simple. Nothing much here changed here. Okay. So this is section 1. Okay. Where you identify the patient details. This is section 2. Okay. Section 2 is supportive care. This is the new thing. What are the 4 points in supportive care? Whether she has a companion. So remember this word, respectful maternity care. There is so much emphasis going on in India and the world, especially in medical colleges in India, about respectful maternity care, RMC. What does that mean? That you have to respect the mother when she comes. You have to effectively communicate with her. You have to offer her a companion. You have to allow her to deliver in the position that she wants. All these are components of respectful maternity care. Okay, that's a very important component of this labor care guide. So whether you've offered her a companion, pain relief, yes or no, oral fluids, yes or no, posture, supine or mobile. So these are the 4 components. And here is how you're supposed to enter. Yes, she's got a companion, Y, no, and D is whether she's declined. Okay, you don't have to go into so much detail, but just remember these 4 points: companionship, pain relief, oral fluids, and posture. Supine is not a good posture. Mobile, she needs to be mobile. Section 3 is care of the baby. So this is similar to the old partograph. Here you have baseline fetal heart rate, decelerations, whether they're there or not. If L is there, it's an alert finding. This is the alert column. Okay. Amniotic fluid, you need to the same what we used to use in the old partograph. If it's clear liquor, use C. If it is meconium, use M. If it is bloodstained, use B. Fetal position, is it occipito posterior or occipito transverse, are bad. Anterior is good. So it's occipito anterior, it's good. Caput and molding, obviously you need to, these were all there in the previous partogram also. And if it's 3+, it is an alert finding. Okay, so these are again the abbreviations that you need to use. Fetal heart rate decelerations, late is the alert one. Okay, amniotic fluid, 3+ meconium, that is thick meconium or blood stained, are the alert ones. I for intact membrane, C for clear. Okay, M for meconium, B for blood stain. Fetal position, occipito anterior is the good one. Okay, P and T are alert findings, posterior or transverse. Again, caput, 3+ is alert, and molding, 3+ is alert. Okay, so these are the fetal things you need to look at. Next comes care of the woman. Again, this was there in the previous partogram. Her pulse, her blood pressure, her temperature, urine proteinuria, and urine ketones. So this is again, this is very simple. So basically, what have we read till now? Section 1 was identification. Section 2 was supportive care, which includes companionship, analgesia, fluid intake, and position. Section 3 is care of the fetus or baby, and section 4 is care of the woman. Okay, now coming to the most important point. Okay, this is progress in labor. All right. Right. So here it has, first thing you need to remember is it has been divided. The partograph has been divided into first stage and second stage. In the old partograph, remember, there was no second stage. Okay, so second stage has now been introduced. Okay, and so what is second stage? From full dilatation of the cervix till delivery of the baby. All right. Now, first stage, that is from, we're talking about 5 centimeter onward, active first stage. 5 centimeter onwards, you start plotting. So how do you start plotting? You can see this 5. Suppose she comes to us at 5 centimeter. We put a cross here. Okay. So it's written here, an active first stage, plot cross to record cervical dilatation. Alert is triggered when the lag time for the dilatation is exceeded with no progress. Okay. So what does this mean? Alert here is written 6 hours. That means if she comes to me at 7 a.m., I can wait till 6 hours. That means till 1 p.m. for her to progress a little bit more. Okay, so if she remains at 5 centimeters for 6 hours, then only after that only I need to get worried. Okay, if she's progressing, suppose after 4 hours I repeat her PV. At 11 a.m. she is now 6 centimeters. So after 4 hours, she's now 6 centimeters. So this is all right. Okay, but if she remains 6 centimeters after 6 hours, then this is when I need to get alerted. So this is a major change. If you've noticed, this is much more than 1 centimeter per hour. So we are waiting much longer for her to progress. Okay. But as long as the other parameters are fine, if there's no fetal distress, mother is fine, we can allow her to progress as long as these many hours. So if she's 5 centimeters, we can allow her to wait for 6 hours. If she's 6 centimeters, we can allow her to be 6 centimeters for 5 hours. If she's 7 centimeters, we can allow her to be 7 centimeters for 3 hours. Okay, 8 centimeters, we can allow her to be 8 centimeters for 2.5 hours. If she's 9 centimeters, we can allow her to be 9 centimeters for 2 hours. So remember this, 5, 6, 7, 8, 9. And what are the numbers? You need to remember 6, 5, 3, 2.52. Okay, so 5 to 9, you have to remember because once she's 10, she comes second stage. But 5 to 9, remember 6, 5, 3, 2.52. Okay, so this is something which you need to remember as far as I think, because this is something which has completely changed from 1 centimeter per hour. Now we're waiting 6 hours at 5 centimeters, then 5 hours at 6 centimeters. So the duration, of course, now has increased. So this is one of the major changes in the partograph. I will repeat, in the first stage of labor, that means in the active first stage from 5 centimeter to 10 centimeter, the alert line is no longer the 1 centimeter per hour line. We no longer say the woman should now deliver within 6 hours if she comes at 4 centimeters. We are now saying we can allow her to be at 5 centimeter for 6 hours, at 6 centimeters for 5 hours, at 7 centimeter for 3 hours, at 8 centimeter for 2.5 hours, at 9 centimeter for 2 hours. And once she's in the second stage, we now start entering here. When she starts pushing, we write P here. So suppose she starts pushing here at this time, we write P, P, P. So we're supposed to encourage her to push, bear down only when she gets the sensation, and then we enter it here. Okay, duration of second stage, 2 hours in a multi and 3 hours in a primary is what this labor care guide now says. So not more than 3 hours in a primary, not more than 2 hours in a multi. Remember these points. Okay, so this is what has changed in the cervicogram. We no longer follow the old cervicogram. This is what is being followed. 6, 5, 3, 2.5, 2 hours between 5 to 9 centimeter. And descent is plotted as before, from 5/5 palpable to 4/5 palpable, 3/5, 2/5, 1/5. This is the same. Descent has not changed. Only this has changed, and it has been divided into a first stage and a second stage. We are supposed to document second stage when she starts pushing also. So I hope this is clear. This will change a lot of concepts of yours, but the WHO has not specified prolonged labor. Definitions have changed. So if you're reading a chapter on prolonged labor, stick to that. If you get a question on labor care guide, then only, if they specifically mention LCG, then only you need to follow these new categories. Okay. If you're simply asked a question on prolonged labor, follow the definitions that you know. All right. So this is not to confuse you. This is just, I'm adding this because in major hospitals like AIIMS and Safdarjung and all, they are following this labor care guide now. So if your faculty has made questions, are your faculties from these major medical colleges, these main medical colleges, then you are likely to get quizzed on this, is what I mean to say. And you should know what labor care guide is. Okay. So this is an example of a filled labor care guide. Okay, the supportive care, initially there was no companion, no pain relief. Then she asked for, then in between again, she had no companion. Okay, similarly, pain relief, oral fluid, posture. This is section 2. Section 3 was the fetal status. Okay, here it was position, then it became transverse, then it became anterior, posterior, transverse, anterior, it became. Okay, so wherever there's an alert thing, it has been circled with red. Okay, then her parameters, maternal parameters are all right. Then you can see she was 5 centimeters here. Then after 4 hours, she became 8 centimeter. Then she became full after another 2 hours. So this is her progress of cervical dilatation. And here she started pushing. Okay, so this is how the labor care guide is now being filled. And these are the alert parameters that you should know in cervical dilatation. Okay, section 6 is medication. I won't go into this. Section 7 is important. So section 7, this is a new one, shared decision making. So what was your assessment and what is your plan? And this has been briefly described as these words. So what will you do? You will first assess her, then record the observation on the labor care guide, check the reference threshold by seeing the alert column, and then make a plan. Okay, decide what intervention is required, if at all. So remember this: assess, record, check, and plan. ARCP, or however you want to remember this: assess, record, check with the alert value, and then plan your management. Okay, so this is the new section 7 which has been added. That means management has been added. Okay, so I hope this is clear. Okay, this is all that you need to know. You don't need to know anything more than this. Okay, for your exam, my main aim is for those writing NEET-PG right now. Okay, because this can come as a question, or in the INICET in May, this can come. So this is why I wanted to cover this, because most medical colleges have started doing number 1 Robson classification, and number 2 they have started doing the labor care guide, and hence you should know briefly about these things. Okay, so question time. For whom should the LCG be used? You can write in the chat box, or unmute and tell me. For whom should be used? Should it be used for high risk women or low risk women? Yeah, good. So low risk women, right? It should be used for low risk women. Okay, 1 second. I'm not able to. Yeah, low risk. Good. Wait. Okay. Sorry. Okay. When should the LCG be initiated? When should we start doing the LCG, the labor care guide? At how many centimeters dilatation? Yes, 5 centimeter. Good. Everybody is answering 5 centimeter. Very good. So the earlier Partograph was 4 centimeter. This is 5 centimeter. ACOG says 6 centimeters. Okay, so don't get confused. Depending on what the question is asked, write the correct answer. Okay, if somebody asks you the old Partograph, it is 4 centimeter. If somebody asks you WHO or LCG, it is 5 centimeter. If the question mentions as per ACOG, it is 6 centimeters. Okay, so that is what the new active stage is. Okay, next question. In which setup should the LCG be used? Okay, I didn't cover this, but the question is there. What I mean to say, in which kind of healthcare centers? In primary centers, in tertiary centers, everywhere, where should we use the LCG? Yes, all healthcare setups. Very good. Should be used in all healthcare setups, whether you're working in a primary center or in a corporate hospital or in a medical college. It should be used. It is a standardized format. It should be used anywhere that you are delivering women. It should be used. Okay. How many sections does the LCG have? Yes, it has 7 sections. Good, very good. So I will just quickly repeat for those, for revision. First is identification. Second is supportive care. Third is care of the baby or fetus. Fourth is care of the woman. Fifth is labor progress. Sixth is medications. And 7th is shared decision making. All right, where you record your findings and then plan what needs to be done. All right, so then, okay, so what is new in this? Supportive care is new, okay? And supportive care includes pain relief, presence of companion, fluid intake, and the position that she's laboring in. All right. Then what else is new? The labor progress does not have an alert or action line. It has a new, different sort of thing now. we start at 5 centimeters and 5, 6, 7, 8, 9 centimeter. We can wait here for 6 hours. We can wait here at this is for 5 hours. We can wait here for 3 hours. Here you can wait for 2.5 hours, and 9 centimeter we can wait for 2 hours. Okay, so I hope this is clear. Okay, next. And the third new thing is assess. After assessing or examining the patient, record your finding, check with the alert thresholds, and then plan your management accordingly. This is called as shared decision making. All right, so I hope this was clear. And that ends the session. Anyone has any doubts? So I've recorded this. I'll put it up on YouTube. Okay, for those who want to revise, I will also share the PPT because you won't find this information much. Those who don't want to listen to a lecture can just check the PPT. Okay, thank you everyone. It was a short session, but I think it was a useful session. And it is definitely important. It's very, very brief, but it's an important area which you should cover if you're writing the NEET-PG. Okay, thank you everybody. Thank you everyone. Bye, good night. What is the name of my Telegram channel? Sana, it is OBG classes by Dr. Rena. All right, I think I put underscore in between. Let me just check and tell you, Sana, 1 second. It is, the exact name is, there's no underscore. It's just OBG class, space classes, space by Dr. Rena. Okay, you'll be able to find it. Okay. If you're not, I'm writing my phone number here. Okay, you can just send me a message. I'll add you to the group. Okay.